Hello, everyone. Welcome to today's Leveraging Lessons from the Past webinar on Lab, Billing, Coding, and Compliance, a 2025 overview. This is Jenna Peterson, a Senior Education Specialist for Mayo Clinic Laboratories. Our presenters today are Pete Duda, Director of Revenue Cycle, Cheryl James, Manager of Lab Coding, and Kathy Patterson, Regulatory Process Manager. All three of our presenters are with Mayo Clinic in Rochester, Minnesota. A couple of reminders before we begin today. There will be a question and answer session at the end of the program. You can submit questions online via the Q&A icon in Zoom. Please only use the chat function for any technical issues. Also, today's program is being recorded and will be posted to our website in a few weeks. And now I will turn things over to our presenters. Pete?
Thank you, Jenna. Welcome, everybody. Thank you for being here today. There's a quick note on the disclosures. So today we have three basic topics or three items that we'll be going over. We'll begin by talking about important considerations in laboratory billing. From there, we'll talk about coding updates and pricing considerations for the remainder of 2025 going into 2026. And then finally, we'll talk about some compliance regulatory items related to laboratory billing. So first, laboratory billing. This can be a complex discussion. It can be very detailed and nuanced. In the time allotted, we're going to go very high level. We're going to provide some resources for y'all to reference after the presentation. For my purposes today, I'm going to summarize these into 5 basic topics: submission, verification, adjudication, payment, and denial follow-up. So moving into submission. So as you perform your laboratory tests, as you serve your laboratory customers, you know the laboratory test menu that's in front of you. Number one, it's important to ensure that you have the appropriate CPT coding according to the American Medical Association methodology or their descriptions. Ensuring that you have the right information up front ready to queue up a claim is vital. You're kicking off the claims process in your laboratory billing workflow. However, CMS has exceptions to the AMA coding methodology, HCPCS code. So I'm talking in acronyms. You have the descriptions here in front of you. HCPCS, commonly referred to as HCPCS code, or G codes. They're an exception to AMA coding methodology. So it's important as you consider how you set up your charge master, your billing system, that for the test services that you're performing, you may need an AMA CPT code, you may need a HCPCS code. Now, overall, as we go through the different fundamentals of laboratory billing, you'll find that at certain stops along the way, you're going to learn, and it's going to inform how you set up your system to prevent errors on the back end. So there's no, easy way when you get into all the different commercial payers and policies and plans to understand what payers are going to require a CPT versus a HCPCS. However, you'll learn as you go along, and as long as you have a laboratory dedicated billing team or an individual along the way that's understanding the denial trends, you'll be able to have that knowledge and set up the billing system appropriately. Now, in HCPCS code, I mentioned G codes. The one that lives large in my head is G coding for definitive drug testing. So the AMA has different CPT codes per drug class. Medicare is going to require one G code that represents 1 to 7 different drug classes. So it's not just a one-to-one match. Sometimes it's some to many, or some to one, or many to one. And you got to keep that in consideration as you set up your system to ensure you're testing the laboratory services that you perform are billing out appropriately. Now, when it comes to ICD-10 codes or diagnosis codes, this is really the opportunity to prove out medical necessity to the payer that's going to be processing the claim. You're relying on documentation in the EMR or information that you're receiving from your external outreach customers to ensure that you're getting the proper ICD-10 codes to place on that insurance claim. The one thing to call out is typically there's multiple diagnosis codes that can accompany a laboratory test. more and more payers are looking for primary diagnosis codes to be in the first spot on that insurance claim. So just know that, there might be a denial at the back end that may lead you to have to reorganize the cadence of those ICD-10 codes. And again, payers are going to vary. It's just not black and white here. So when it comes to diagnosis coding, yes, it needs to be the appropriate diagnosis code. But sometimes when you have multiple diagnosis codes, you need to ensure that they're in the right order on the claim. Going back to CPT coding and HCPCS code, there's also MUE considerations. Now, a MUE is a medically unlikely edit. It's a way for Medicare to limit the number of CPT code units that are reimbursed on a given day. For instance, you might perform a service. The AMA will allow you to code that with 3 units of the CPT code. Medicare may limit reimbursement to 2 units. Now, the consideration here is there's an opportunity on the back end. You might disagree with that MUE. You might want to appeal that limitation, that denial with Medicare. However, there are going to be payers where if you file 3 units to the payer for that test or that CPT code with an MUE limit of 2, that payer is going to deny all 3 units. Versus if you file that same claim with 2 units of that MUE, they're going to pay the 2 units. So sometimes you have to ensure that your system set it up to bill down to the MUE versus above it, because you might get a full denial for that claim. Additionally, Medicare has procedure edits. These are 2 CPT codes that can't be billed together on a given service date for same patient, same provider. So these are 2 codes where Medicare and other payers are going to look and say, this is a primary code. We're not going to pay on the other code because it's bundled or hitting up against the primary procedure. And all the work that you can understand and with MUEs, with P2P edits, you're setting up your system up front to ensure that there's limited manual effort on the back end to ensure that you're efficient in your workflows and you're really saving your time and your staffing to focus on more complex denials and just some system setup that can be configured within your software. Once this laboratory test is performed, you have the coding all set up, you're adhering to the MUEs if you deem them appropriate. Second step is verification, confirming accuracy of the patient information that you're receiving. Now, these might be patients you're registering where you have the insurance information. These might be outreach patients where you're relying on your customers to provide the insurance demographics. But in today's day and age, there's very automated, efficient, real-time ways for you to validate that the insurance information that you received is accurate, up to date, that the payer insurance didn't lapse overnight, that they're not now qualifying for Medicare or have a different commercial payer primary or even a new supplemental insurance secondary. So EDI, electronic data interchange, it's a way for you to use consistent data formats and files to receive real-time information or electronic information from payers or different payer third-party vendors. When confirming the accuracy of that data, so through EDI, your billing software can receive real-time benefits check and eligibility, and sometimes use that to do cost estimations as well. It's really efficient. It's kind of the new standard that are out there. A lot of payers, or excuse me, a lot of revenue cycle teams have upwards of 95% of their payers set up with electronic data interchanges and performing all kinds of different real-time system checks to ensure the accuracy of that patient data. But you can still log into a payer website to achieve that verification. You can use a third-party vendor, which will validate the eligibility of a patient. But even if you find out that the patient isn't eligible or no longer have that insurance, there's vendors out there that do insurance discovery in some manners. Some of that can be integrated into your EMR, your billing systems as well. But it's just other opportunities for you to kind of use technology, software integration to receive updated and appropriate insurance demographics for the patients that you're serving. You can work through clearinghouses as well, which is kind of the company and the software that sits between providers and payers. And what's nice about a clearinghouse is you're integrating with one clearinghouse, and then the clearinghouse responsible for integrating with multiple payers. So it reduces some of the enrollment setup and interfacing. instead of going payer by payer. Now, when you do these EDI transactions, there's a standard set of formatting and logic, and this just gives you a little brief overview on some terminology here. When it comes to checking eligibility and benefits, it's 270, 271 transactions. So if you're talking to your rev cycle team or IT, you might be wanting to ensure that you're enrolled in EDI, and they're coming back to you and saying, do you just need 837 to submit a claim, or do you need 270, 271 transactions, et cetera? So just some information here that you can reference. Adjudication. So the payer has, you've validated the patient information, CPT coding, diagnosis codes on the claim, everything's looking good. You're finally sending that insurance claim out to the payer, and now it's going through that insurance's adjudication system. Now, at this point, there's really a benefit and a value to understand, coverage and outcomes. When it comes to commercial payers, by plan, by insurance, there's going to be different coverage policies, different considerations for when a test is considered medically necessary or not. You might understand at this point whether or not a prior authorization is required, et cetera. And unfortunately, some payers are really good about publishing these policies and making it clear when certain testing is covered, when it's not covered, what diagnosis codes are required to secure coverage, et cetera. But the reality is sometimes it's not that clear, and only through experience are you going to understand coverage and outcomes. But through adjudication, it's just ensuring that you understand the payer in question and what type of requirements that they may have to cover that insurance claim. When it comes to Medicare, there's national coverage decisions and local coverage decisions. Local coverage decisions are determined by your Medicare, your local Medicare administrative contractor. Happy to say Kathy will get in a little more detail on these items further on in the conversation here. But when you think about your MAC, your Medicare administrative contractor, it varies by region. So when you think about who you're supporting in your laboratory business, you may have situations where, as a billing provider, you are going off of the local coverage decisions of the MAC in which your state resides. So the billing provider takes precedent in terms of Medicare coverage decisions. However, your customer might be in a different jurisdiction, and they might have diagnosis codes that fit the local coverage decision in that MAC region, and that might conflict with what you're doing as a billing provider. And to give you an idea of how many different MACs there are and regions there are across the US, this is a nice map that CMS makes available. And just to touch on some of the complexity. In Minnesota for Mayo Clinic, our MAC is National Government Services, or NGS. We have LCDs. In Arizona, our other Mayo Clinic site, they have Noridian, different set of coverage policies. And to make things even more complicated for our institution, Florida is under a First Coast Medicare administrative contractor. And that just provides an opportunity for differences in coverage. And as you try and set up your system to accommodate all these different scenarios, it just adds to the complexity, some of the administrative work and effort to keep up with this, with all the varying coverages that may be out there. Going to get in the happy path. Happy path is where we get a payment and we're able to capture reimbursement. And as you receive payment, you're going to get electronic remittance advice if you're signed up for EDI, or you might get a paper remit. Now, these are also known as explanation of benefits. So as that payment comes into you, hopefully it's a payment, you may still get a paper check delivered through the U.S. mail. Some payers are even sending or emailing one-time credit card numbers to pay for these claims, but the best, most efficient route forward is to ensure that you're signed up with the insurance and the electronic funds transfer. So it's a bank transfer, it's very timely, it's quick. You can marry up the electronic funds transfer with the electronic remit to ensure that you understand the payments coming in, as well as any of the other denials or remark codes that are on the remit associated with that patient claim. As we think about applying payment, it's vital that it's done timely, because at the end of the day, not only is the patient awaiting their laboratory result to help with their patient care, but they're also waiting for their cost sharing, wanting to understand how much they're going to have to pay out of pocket. So co-pays, co-insurances, deductibles, and as timely as you can get that payment posted, as you can get the electronic agreement applied to that claim, the quicker you can get that invoice out to the patient, should they have any remaining responsibility. Now, the value here is after the insurance processes that claim, the insurance will send the patient an explanation of benefits. Patient will open that up in the mail, or at least I do, see what I owe my healthcare institution, and then the quicker I get an invoice that relates to the EOB, the easier it is for me to tie two and two together, so that I can understand, okay, this invoice from Mayo Clinic relates to this EOB that I received a day ago or 2 days ago, et cetera. And it just provides added comfort in understanding that that healthcare bill is appropriate. As a revenue cycle individual, I do acknowledge and experience myself that healthcare billing from a patient standpoint is confusing. So the quicker you can get this information processed and connect the two dots between the insurance EOB that they deliver to their member and the invoice that you're delivering to the patient is vital and provides a lot of benefit to the patient experience. Unfortunately, we don't always have a happy path. Upwards 25, 30% of some insurance claims for certain services will be denied. And from here, you need to ensure that you're able to correct those insurance claims, dispute, appeal those insurance claims, ensuring that you're receiving the appropriate reimbursement for the laboratory testing that you're providing your customers, your patients. And the one thing to call out here is you need to maintain knowledge of payer specific forms and protocols. Now, not every denial will require an appeal. You'll have to have knowledge of which types of denials can be corrected with a corrected claim or updated information submitted on a new claim. If you do get into a position where you need to appeal the denied claim with the insurance in question, there's going to be payer specific considerations. Some payers are going to require that you log into their website to submit a payer appeal. Some payers are going to require that you download a specific form that they have to include with all the information that you're sending in with the appeal. Some insurances will take whatever form document you have, and once that's received, they'll process the appeal and consider it for reprocessing for payment. However, if you're not following that payer-specific procedure on how to appeal a denial, they're not going to consider it. So ensure that you have a team that's maintaining knowledge of what every payer is going to expect. Second bullet here is housing the appropriate documentation. And this is a consideration up front. This is consideration on the back end as well. Whether there's a post-claim audit, Medicare, Medicaid might do a SIRS review or a surveillance and utilization review, where after they process the claim, after it is even paid, they can go back and say, okay, I want you to prove out medical necessity. So show me the record in the EMR that, this diagnosis code was pulled from. Show me the physician order. Show me that this test was actually performed. Now, many times these are back-end, individuals that, have a lot of work on their plate. A lot of administrative effort goes into these audits, these SIRS reviews, and ensuring that they have easy access to this documentation is vital to meet the deadlines that come with these audits, these post-claim reviews. Now, as a reference laboratory, we understand we might not have all the documentation in place. Our customers, have the EMR record that would prove out the medical necessity of that diagnosis code. They would have their physician order signature on the laboratory testing question. So sometimes the appropriate documentation is a partnership with your referring customer or your providers in-house that are ordering this testing, but ensuring that there's as easy as access as possible is extremely important here. Consulting with experts. Any rev cycle team is only as good as the team that supports it. When it comes to working denials, appealing denials on the back end, your rev cycle team might be housed with a lot of great information, but at the end of the day, they may need to work with the ordering provider to prove out medical necessity. May need to work with the laboratory to understand the methodology or the algorithm of the testing in question to prove out that the CPT coding was appropriate. They may need to work with revenue compliance or legal, other administrative support teams to ensure that they have the right information to dispute a claim, overturn a denial for payment, et cetera. It's not just one person that's going to have all this information. It's not just a send out lab that's going to have this information. It's really a partnership, and you can't be on an island and expect great results in terms of denial follow-up and some of the information you need to prove out your case with the payer. Finally, adhering to deadlines. You put in all this work to submit the claim, to get a payment or a denial, work to accumulate all the documentation needed to appeal that claim. You need to ensure that, one, if a payer has a limitation that you can only appeal within 30 days of a denial or 60 days of the denial, you need to ensure that your workflow is accommodating that. You don't want to put in all this effort only to find out that you're timely filing to file an appeal expired 3 days ago, 5 days ago, a month ago, whatever the case may be. So ensure that you understand when you work with a payer, and it even goes to submitting your initial claim, what is their timely filing? What deadlines do they have in place for allowing not just the first appeal, but the second appeal and the third appeal? And in cases of Medicare, you can find time in front of the judge if needed to speak your case on why you feel your testing should be reimbursed. So all in all, each step that we just went through, you're learning things along the way. What you learn is going to inform what you can do on the front end to prevent denials and bad outcomes on the back end. And that's really the goal here. Kind of a continuous learning curve, whether it's, in the denial and follow-up portion of the workflow, or when you're reviewing payer policies or MUEs, you're really striving towards ensuring your system is set up appropriately to send the right information to the insurance, but also ensuring that if there are documentation requirements that are going to come to prove out medical necessity or a post-claim audit, that where you can get that information up front to make the experience better on the back end for your teams. So with that, I'll pass the torch over to Cheryl to talk about coding.
Thank you, Pete. As Pete touched on at the beginning of his presentation, CPT codes are extremely important. I'm not going to spend a lot of time on this slide since we're already, 7 months into 2025. I do want to point out, though, that there were 5 new codes in 2025 that really relate to the biomarkers associated with Alzheimer's. Those are the beta amyloid codes, the neurofilament light chain code, and the tau codes. Next slide, please. So 2026, the 2026 AMA CPT editorial book will be available generally late September to mid-October. A lot depends on how soon that they can get those out to the warehouses to ship. But we know based on the CMS clinical laboratory fee schedule listing for codes that we had to go to CMS the last week in June to recommend pricing, that these are the new codes we're looking at in the lab path area. You'll note that there are 2 susceptibility study codes for the carbapenemase enzyme detection and the carbapenem resistance genes. We have an infectious agent antigen detection for SARS-CoV-2 and influenza A and B. This is more a point of care testing. Note it's direct optical or visual observation. In the molecular area, we have the oncology central nervous system tumor DNA methylation analysis. We also have infectious agent detection for joint space pathogens, and we have one for chlamydia and gonorrhea. And then we have the cytogenomic genome-wide optical genome mapping for constitutional number variants. Next slide, please. I'm going to talk a little bit about the PLA codes, or the proprietary laboratory analysis codes. And this is because these codes make up the majority of the new codes that come in each year. Most application cycles, there's anywhere from 30 to 60 codes each cycle. These codes are proprietary to a single laboratory, and only that lab can use the code, or they're specific to a vendor. And if the laboratory is using that vendor kit per manufacturer instructions, then you can use the PLA code. These are codes that are a 4-digit number followed by the letter U. These codes become effective 4 times during the year: January, April, July, and October. So it's very important to keep up with the publication of these codes and know when these codes will be effective so that you are coding appropriately. If you have the AMA CPT book for 2025, your PLA codes contain 001U, which was the very first code, through 0520U, and those are on pages 720 to 747. What you want to look at, though, is really that Appendix O, which is our pages the 1040 to 1095, because that's where you find that proprietary entity for the code. So unless that proprietary entity is, for example, Mayo Clinic, we cannot use a code that does not say Mayo Clinic owns that, or if it's a vendor, if we're not using it per that vendor instructions. Mayo does have a lot of proprietary codes, and if you're familiar with our test menu, you'll recognize that some of our CPT codes do end in this U. For PLA codes that aren't in the book because of this publication cycle, you'll want to go out to the AMA site and always look at that long code descriptor at the bottom of the page. And it's always a PDF file. It'll show you the approved date, the effective date, and the publication date. Next slide, please. And this gives you an idea of what that file looks like. So you can see in that second visual that you've got the proprietary name, and it'll tell you who owns it. So in that first example, you'll see that it's for quaking-induced conversion, and it's from the National Prion Disease Pathology Surveillance Center. So they're the only ones that can use that 0035U. This was just an editorial change, which became effective on July 1st, was released to AMA on July 1st. It'll be effective on October 1st, and we'll see that published in the January 2026 book. The only change to this code really is the fact that there is now going to be another PLA code very comparable for real-time quaking-induced conversion. And I can tell you that that is a code that Mayo Clinic has got for one of our tests. So this gives you a good idea of what to look for. What I'd like to finalize with is always ensure you're using the most appropriate code. There's a lot of codes out there, and you really need to do that due diligence to look at the method that's being used, the analyte that's being looked at. Read any guidance information that's in the AMA book, or if you've got access to Codify, there's a great lay description. And I know Kathy's going to touch on Codify in her section, giving you tools for what we look at. So with that, I'm going to turn it over to Kathy to go into more detail.
All right, thank you. So now that we've heard about billing and coding from Pete and Cheryl, I'm going to shift gears and talk about the importance of compliance and share some tools and resources with you that you can utilize to help you remain compliant. So first, let me say that I believe everyone on this call wants to do the right thing and be compliant at all times. But sometimes we simply don't know all the rules. There's a lot of them, right? So, of course, someone else may have trained you to do your job and some of the things that you do, and they believe that what they were telling you was correct, but maybe it wasn't 100% correct. So it's important to understand the consequences of billing or coding something incorrectly or not complying with all of the rules and regulations. I'm sure you've all heard in the news of healthcare organizations that were found to have fraud and abuse in their billing practices, or that they had violated the anti-kickback statute. And you may have heard that they had to enter into settlement agreements with the government due to the overpayments they received as a result of their inappropriate practices. And you may have even heard of some executive or managers who have been sentenced to prison. While I may share a recent fraud enforcement action at the end of the presentation if we have time, that is not my focus today. My focus today is making sure you know where to find the key guidelines and rules and to give you the resources you can utilize to find answers to your questions about billing and coding. Next slide. So here are some various resources that I've kind of categorized here. That you can utilize when you have a question. And we're going to dive into each of these as we go through the next slides. Next slide. So what are statutes? So statutes are laws passed by either the U.S. Congress or state legislatures. The legislatures create bills that when passed by a vote, those become statutory law. Here are some examples. The Social Security Act and 42 U.S. Code subsection 1395Y. I've included the links for these, but basically these are just a couple of examples of statutes that have been passed. The Social Security Act addresses how labs are paid, and the 42 U.S. Code subsection there is related to exclusions from coverage. Medicare is the secondary payer, secondary payer, and it also addresses the terminology of reasonable and necessary. Next slide. So regulations. Regulations are standards and rules adopted by the various administrative agencies that govern how laws will be enforced. So here are some examples. And again, I've included the links. You will see that these come from the Code of Federal Regulations, also known as CFR, and Title 42, which is related to healthcare. There are many more of these out there, and you will see I access these at the website www.ecfr.gov. The first example here is guidance related to the date of service for laboratory and pathology specimens, and you'll find that at 42 CFR 414.510. And then lab test report requirements, and you can find information at 42 CFR 493.1291. So if you have questions about data service or lab test reporting, then these regulations might help you with your questions. Next slide. So we're going to talk about NCDs. Pete's already mentioned it, and just to reiterate, these are national determinations of whether Medicare will pay for an item or service. They are made through an evidence-based process, and the public has an opportunity to participate and comment on these. So these are located in the Medicare coverage database, and I've provided that link here at the bottom. You can also get to these most of the time through the MAC websites. They'll have a link that takes you into the Medicare coverage database. But regardless, the NDC that you'll find will outline the indications and limitations of coverage for the test in question. As of June 19th, when I last looked, there were no NCDs published out there for public comment, but you can periodically go back and look at this website to look for ones that you may want to comment on. And here are a couple of examples. There's an NCD 190.23 related to lipid testing and an NCD 210.1 related to prostate cancer screening tests. And of course, there's many more out there, but I just wanted to provide a couple of examples. And next slide. So the one thing you should know about NCDs is you may go out there and look for an NCD for a particular test or service, and you may not find one. If you should decide that there needs to be an NCD, you can request a new one. Or perhaps you find an NCD and you think something about it needs to be changed. So this slide here is about requesting what's called an NCD reconsideration. And there are two criteria. One of these two criteria have to be met in order to submit an NCD reconsideration request. There either needs to be additional scientific evidence that was not considered during the most recent review of that NCD, or if your organization has a plausible argument that in issuing that NDC decision, that their conclusion was materially misrepresented by the existing evidence. And so for more details about this NCD reconsideration process, I've provided you the link at the bottom of this slide. And next slide. And so again, you can request a new NCD, excuse me. Your request must include the clearly defined benefit category that this test or service would fall under. You need to provide supporting evidence and documentation to support your request. It needs to include information on the usefulness and benefit of the Medicare population. And it needs to include a complete explanation of the design, purpose, and method for using that item or service. CMS will tell you that this process usually takes 9 to 12 months, but that time frame doesn't start until CMS actually formally accepts your request and posts a notice on their website. And so for additional details on the process, you can go to the link that I've provided here at the bottom of the slide. And so LCDs, local coverage determinations, contrary to NCDs, which apply nationally, LCDs are the local coverage policies that are applicable to a particular MAC jurisdiction. Here are a couple of examples. For example, Noridian published LCD L36700 related to serum magnesium, and they published that for their jurisdiction F. NGS published LCD L39611 for urine drug testing, and that was for their jurisdiction 6 and jurisdiction K. The NCDs and LCDs are important to review, particularly when you start providing a new service or a test so that you understand what may or may not be covered. They're also helpful when you're reviewing denials for medical necessity. And just as with NCDs, you can request a new LCD or a revision to an existing LCD. And before I go any further, I want to also mention that for LCDs, there's usually a corresponding LCA, a local coverage article, or a billing and coding article. And while the LCD addresses whether the service is covered, generally speaking, the LCA, or the billing and coding article, will typically list the specific diagnosis codes for which the service is covered. And so, as I said, you can request an LCD reconsideration, and it's very similar to that process for an NCD reconsideration. And here I've shared the things that the MAC is going to look for in an LCD reconsideration request. I pulled these particular requirements from NGS, but generally speaking, all the MACs basically have the same requirements. They may articulate it a little differently on their websites, but in essence, they're going to look for the name and address of the provider, the beneficiary that's making the request. They're going to want your email address, your telephone number is optional, and they're going to want to know which particular LCD are you requesting a reconsideration on. And then most importantly, these last two bullets, they are going to look for you to provide copies of published evidence and language that you want added to or deleted from the LCD. I've also shared some examples of when you may want to request a reconsideration. For example, if there's an LCD for a particular lab test, this does not include coverage maybe for a specific type of cancer, or maybe the LCA doesn't include a specific diagnosis code that you feel should be covered. then this may be the route that you want to take and submit an LCD reconsideration request. You may also receive a denial, and in researching a denial, you discover, that this particular test and diagnosis code are not covered, but your physician who ordered it is telling you this is appropriate for the patient based on the patient's condition or disease, and feel strongly that the diagnosis code should be covered. And that's when you would want to consider filing a request for reconsideration. Now, it's not going to immediately solve that particular claim denial, but it will help you get the policy changed so that moving forward in that scenario, it would perhaps be covered. And you may be wondering how long this process takes. I will just say that it can vary significantly, particularly by MAC. In some cases, I've submitted a request, and within a matter of a few days, the MAC has asked to have an informal meeting with us, with their medical director. And before everyone can even get on the call, I've had the medical director tell me this was an easy decision for him, and he would have the LCD published with the revision ASAP. And within a matter of a couple of weeks, the change was made to the LCD and it was published. In other cases, you can submit a request, and I've had 10 months go by before I hear anything. So it truly does vary, oftentimes based on the complexity of your request and also based on the volume of requests that they're receiving at the MAC. So next slide. And so again, here I've outlined how to request a new LCD. And again, I've provided here the information of what NGS lists as their requirements. But again, it's pretty similar across all of the MACs. They're going to look for the request to be in writing, and you can provide it by various mechanisms. They typically provide an email address you can send it to, you can fax it to them, or you can mail it hard copy as a written letter. Your request must, again, very similar to the previous slides, you must include the statutorily defined Medicare benefit category. And generally speaking, you're going to find that in the Medicare Benefit Policy Manual. Your request should identify the language that you want changed or added. In this case, it's a new one. So they are looking for you to craft what you think that LCD should say. And you should, of course, provide justification that supports that this test should be covered. It needs to be peer-reviewed evidence. It needs to be published evidence. And they're going to look for you to actually provide those in a PDF format. The request should also contain information that addresses the relevance, the usefulness, and the clinical outcomes and the medical benefits from that item of service that you're seeking coverage for. And the request must include information that fully explains the design, the purpose, and/or the method that's used for that item or service for which you're making the request. So now that we've walked through all the NCDs and LCD requests and reconsideration requests, we're going to hop back to our little list that we had in the beginning of all the resources. And I just want to touch on the CMS manuals. I'm sure many of you are familiar with the various CMS manuals, but for those who aren't, I've provided a list here and on the next few slides. We'll have Pete flip through these fairly quickly, but I just wanted to make you aware of them. And as you would suspect, you can find these at cms.gov. And here on this first page, you'll see the Medicare Benefit Policy Manual, the Medicare Claims Processing Manual, the Medicare Secondary Payer Manual, the NCD Manual. You'll also see on the list here on this page that's up now, the Medicare Program Integrity Manual, which you may find useful. And I'll just also point out that you'll see that there's a Medicaid state CHIP manual that's under development. So it'll be interesting to see what's contained in that manual when it's published. And then the next slide, I think, is the last one. And we'll just move on to the next slide. Here, I've outlined for you how to access the CMS manuals. And I've provided a screenshot as well of instructions here. So basically, you just go to cms.gov, click on the Medicare tab, then click on Regulations and Guidance, then click on Manuals, and then click on IOMs or Internet-only manuals. So I want to go over the Medicare Benefit Policy Manual and the Medicare Claims Processing Manual a little bit in more detail with you, because if you're involved in billing and submitting claims, these are probably the two that you're going to reference most frequently. And that's again, the Medicare Benefit Policy Manual, which is also known as Publication 100-02. And here you'll see I have provided a couple of different references. Of course, there's many more, but these are ones that I frequently reference. I often look at Chapter 1 for inpatient hospital services covered under Part A, and specifically I look at Section 50.3, which is about diagnostic services furnished to an inpatient by an independent clinical laboratory under arrangements with the hospital. And then there's Medicare Benefit Policy Manual Chapter 15, and it has numerous sections that I reference, but here are some of the ones that are more frequent. It covers requirements for ordering and following orders for diagnostic tests and when you can order additional testing. So if you are looking at the rules for a physician who may determine that a different diagnostic test is appropriate, you would look at Section 80.6.2. And for example, if you wanted to know more about surgical and cytopathology exceptions, you would look at Section 80.6.5. And the next slide. This is the Medicare Claims Processing Manual that I use most often, Chapter 16 for laboratory services. And again, you'll see various sections outlined here. So if you have questions about the place of service, for example, what place of service code you should be utilizing, you can look at Section 30.3. If you're a laboratory billing for referred tests, you might need to look at Section 40.1. If you have questions about the date of service, Section 40.8. If you have questions about specimen collection fees, you would need to look at Section 60.1. And then if you have a question about tests being performed more than once on the same day, Section 100.5.1 may have the answer to your question. And next slide. So here are some other resources you should consider using. I would encourage you to check out the CMS website and your MAC websites when you have questions. But if you have a question about a particular subject, most likely others have had the same question. And when they continue to get the same questions over and over again, they're very good about publishing special articles or FAQ documents. So for example, here I've referenced a FAQ that was published by CMS related to lab data service. I've also provided an MLN Matters article regarding the data service, and I've shared here a link to NGS's education on surgical pathology billing tips. And again, of course, there are many, many out there, but I would encourage you when you're looking for resources, as you see, these came from cms.gov website and one of the MAC websites. And on the next slide, here are some other resources I find myself using frequently. For example, the American Pathology Foundation, APF, you may hear it referenced as, has a pathology service coding handbook that provides a wealth of information when it comes to billing pathology services. As Cheryl mentioned, we like to utilize the AAPC or Codify for any coding questions, but a lot of times, since I'm not a coder, I just phone a friend and call Cheryl if I have a specific question. There's also an AAPC coder specialty guide for pathology and laboratory that is very useful. And if you have questions about what information you should be placing in a particular box or form locator on the UB or 1500, there are, of course, these two manuals, one for each, that you may need to reference. And the next slide. So for those of you who want to know what is on the horizon in terms of planned audits, I've shared the link to the OIG Workplan and the approved RAC topics list that's published by CMS. I will mention that the most recent item on the OIG Workplan related to laboratories was a report number OEI-09-25-00330. It was recently announced in June of 2025, and they expect it to be published and completed by 2026. And here they're going to do a deep analysis of the top 25 laboratory tests based on 2024 data. So it'll be interesting to see what that report provides us. It'll likely provide us insight into things that they may look at in the future in terms of audits. And then for the approved RAC audits, if you go out to this link that I have provided here, you will see that there's a list of 144 items currently. But I'll just mention a couple of examples so you'll understand what's out there. For example, one is an issue named 0205. It's about next generation sequencing. And this is an approved audit for all MACs, and the website will tell you that. And it will also provide you the list of codes that they're specifically going to be looking at. Now for this one, it is related to 3 specific PLA codes, 011U, the 0022U, and the 0037U. And if you click on that issue, it will then provide you with a list of all the applicable guidelines, regulations, manuals, etc., that they're going to do their audit based upon. So that gives you an indication that, okay, heads up, I might need to go look at all these resources and make sure I understand all the rules and I'm doing all the right things. And another example, sometimes they will publish and approve an audit for just a specific MAC. So for example, there's an issue named number 0143 that's out there for vitamin D assay testing. And the affected codes are CPT codes 82306, 82652. And they approved this just for the Noridian MAC for their jurisdiction E and jurisdiction F. And so finally, the last thing on the slide here, for those who want to view enforcement actions taken by the OIG, the Office of Inspector General, I've shared the link to the OIG HHS enforcement site where you can read about cases where individuals and/or companies were prosecuted for filing false claims and violating various federal laws. And in these cases, you'll see that individuals may be sentenced to time in prison. In some cases, there's an order for restitution. Their assets are often seized. They are often barred from participating in billing the Medicare and Medicaid programs moving forward. I personally refer to this site as the what not to do site. So if you want to look at what you should not do and what others have done, this is the site you would go to. And I'll just mention, as I said in the beginning, I'll mention one recent case. On June 30th of 2025, the Justice Department announced charges against 324 individuals in a nationwide healthcare fraud, what they're terming a takedown, involving $14.6 billion in false billing schemes. This is the largest healthcare fraud enforcement action in the Department of Justice's history. It's more than double the size of their last major takedown, which was $6 billion. This particular scheme involved everything from telemedicine to genetic testing to durable medical equipment and more. It included common fraud tactics, including what is termed phantom billing, which is billing for services or supplies never provided, and upcoding, which is billing at a higher rate or more expensive service than what was actually delivered. In this particular takedown, the government seized over $245 million in cash, luxury vehicles, cryptocurrency, and other assets as part of the enforcement effort. They also announced that they had prevented $4 billion of claims from being paid as they took some preemptive action prior to the actual takedown months beforehand, and they suspended billing and revoked the billing privileges for 205 providers involved in this. The civil charges are also filed against 20 of the defendants for $14.2 million. And there have been civil settlements with 106 of the defendants totaling $34 million as part of this takedown. All this to say, enforcement action is very prevalent, and there is an increased focus in ensuring that the Medicare and Medicaid programs are not being abused. And so just a note to us all that we should make sure our documentation supports everything that we're billing. So that wraps up our official presentation. We do appreciate you all joining us today. And if we have, I think we have a few minutes here, we may be able to take a couple of questions. Just please keep in mind, we may not be able to answer very specific questions that may require research. But if you have some general questions, we'd be happy to address those or at least point you to a resource where you may be able to find the answer to your question. And with that, I think we'll open up for some questions.
I'll kind of start with one that we received, and that is wondering if the slides will be available for people to view, and they are available on our website currently, where you can download those to access all of the links and things.
If MUE is over, do I enter in the claim only the max quantity or the one with the allowed MUE and the GZ, the ones that are over? So I think that's going to be payer by payer. So some payers are going to want to see the exact number of CPT codes in the claim field in order to pay. You can, work with your payers. Some are going to, accept the additional units on another line with that GZ modifier. Some payers won't require that. So I think there's a few different ways that you can go about, and it really comes down to the payer that you're working with. Cheryl, this might be a good question for you. What is the benefit of a PLA code? We have seen issues with reimbursement for these codes.
The PLA codes have presented challenges for reimbursement. The advantage of the PLA code has been for a lot of these new esoteric tests that we have a code that more accurately reflects the testing that's being performed. Some of these tests are fairly complicated, and the methodology codes just really aren't adequate for those. We're able to take them to CMS for pricing, which helps, get that reimbursement up. But again, if it's not covered, that doesn't help anyone. So I think more attention needs to be given to the PLA codes to ensure as you're getting PLA codes, you're also looking at working to get that coverage decision like Kathy touched upon earlier, and working with your payers to ensure that you've got the clinical utility studies that'll support the medical necessity for the testing.
Thank you, Cheryl. Next question, do you have any suggestions for setting up a process for implementing new testing to avoid mistakes? So I think just referencing back to what Cheryl was detailing about the considerations that need to go into place to ensuring that you have the right CPT coding, but then, depending on, it's taken to a kind of a billing angle of the test setup, depending on your region, your payer mix, I would suggest working with your top payers to understand reimbursement and coverage for that CPT code, and ensuring that if there's any considerations on upfront setup, that you're able to tackle it from highest percentage of payer down. You might not be able to get to all the payers that you would like to, just with the amount of time that goes into that research, but just trying to maybe do the 80-20 rule, taking care of 80% of your patients, deal with 20% of your payers. That might be an opportunity for you. Okay. We are at time. I know questions are starting to come in, so perhaps we'll see those afterwards and be able to get some responses out for those that had a specific name attached to those questions. But thank you all. Really appreciate your time here and interest in these topics today.
Yes, thank you all for participating in today's Leveraging Lessons from the Past webinar on lab billing coding and compliance. If your question was not answered during today's session, or if you have any additional questions, please include them in your evaluation, and you may reference the link to that evaluation in the chat now. Laboratory credit is extended for this program, and upon finalizing your evaluation, you will have the option to claim credit and print your certificate. As a reminder, the program was recorded and will be archived on our website in a few weeks. Thanks again for joining us today, and have a great day.
Thank you for participating. Please click the button below to complete the evaluation and obtain credit.